Hey everyone. What I wanted to cover this week for our video blog was a bell curve distribution of codes. And one of the questions I often get asked is, if I bill higher level codes, am I more at risk for audit? And the answer is, if you understand the reason that you're billing codes a specific way and you're using a specific methodology to arrive at the code that you're billing, and you're providing care that is appropriate to manage a specific clinical situation for a specific patient, and your documentation and your billing reflects that care, then you ought not to be concerned about billing higher and just specifically triggering audits. And here's why. Is because when insurance companies and auditors look at the level of code that you're using, they're looking more at the distribution of code that you're using as opposed to the level of code that you're using that would find an audit. So what you're seeing here is if we gather information about a couple different providers as well as average peer utilization, then we can look at the different levels of codes that people would be using. So in this chart that you're seeing here, you'll see that in the blue are the numbers of codes percentage-wise that you would expect for somebody in optometry to be using for 99201, 99202, 99203, etc. And this would be obviously for new E&M patients. And you'd expect for new patient encounters about 3% of that new patient encounter should be a 99202, about 20% should be a level 3, about 70% should be a level 4, and 6% should be a level 5. So if you're outside of the boundaries here, if we look at provider A, they look way more suspicious in terms of auditability because 79% of their new patient examinations are level 3 compared to provider B, who uses significantly more level 5 and level 4 codes for their new patients. But they're much more in line with what you would expect to see based on national averages. So bottom line with this is that if we look at provider A and provider B bills higher level codes, but when we look at provider B compared to everybody else, they're much more in line than provider A, who bills lower level codes on average, but who is outside the normative bell curve distribution for those procedures. So let's look then at established patients. Again, this information comes from CMS data, and for level 2 codes for new patients, you'd expect about 14% to be level 2 for an established patient, 51% to be a level 3 for an established patient, 30% to be a level 4, and about 4% to be a level 5 for an established patient. And again, if we look at provider A and provider B and we evaluated them as to who would be a more likely risk for audit, provider A bills every single follow-up established patient with a 99212. So they're never using any other codes, as opposed to provider B, who uses a lot higher level codes, but those codes are distributed in the same way that you would expect, or a very similar way that you would expect for our profession to bill. So bottom line is, if we're looking at provider A and provider B as to who is at higher risk for audit, it's going to be the one that's outlier, and that would be provider A. And he's billing lower level codes, and so he's at a higher risk for audit, not because of the lower level codes, but because that's all he's using. If you look at eye codes, ophthalmological codes, we would expect about 60% to come from comprehensive and 40% to come from intermediate codes. So now what I want to look at then is a specific example. So this example came from a doctor who used our iCode billing and coding course, and we looked at his pre-course information, his CMS data, just CMS, not Blue Cross Blue Shield, not United Healthcare, but you could assume that that is a similar distribution, pre-course versus post-course, once he understood how he was billing and how the level of care he was providing reflected in that billing. And so then we look at his post-course year. So what you're seeing here on the bar graph is in gray is his pre-course year, and in blue is the post-course year. And what we're seeing on his pre-course year was that he had 172 visits for about $16,000 in revenue at about $93 per visit per revenue. And what he was doing was mainly using, for established patients, either a 92014 or a 99212. For new patients, he was always using a 92004 for those visits. And so again, he's at a higher risk for audit, but he's also not maximizing his revenue for the services that he's providing. In his post-course year, you'll see once we showed him how to use 99213s and how to use 92 code versus 999 codes, then he saw more patients that year. That could just be from growth. So he had 218 visits. With about $25,000 worth of revenue, and his revenue per visit was increased to $115 per visit. And so what you'll see is that he's taking in his post-course, he's using a lot of the principles that we use versus when we think of 99 versus 92 for new patients and established patients, and he's billing more of those more appropriately. He does also have some level 5 visits here as well, which he didn't have prior to the course. He almost never uses a 99212, which is appropriate. And then he's using more 99203s, obviously more 99213s, and more 99214s. And also you'll see that he's using intermediate codes more, and he wasn't using those at all. So again, if we look at him pre-course versus post-course, he's making more money, he's generating more revenue, but he's also at a lower audit risk because his code distribution is more resemblant of a correct bell curve. So I hope this video was helpful. If it was, please like and share it, and I'll see you on the next one.